Hello, this will be our 11th lecture on the behavioral science course. Um, the topic we will cover today is psychological therapies. This will make a link with a new series of lecture that we will begin shortly after this, which will be on mental disorders as categorized by the DSM-5. Now, mental disorders, the treatment for many of those mental disorders are either pharmacological, that is to say, medications, or psychological therapies. So, in the same manner that there are various pharmacological treatments for different disorders, so benzodiazepines and antidepressants and anti-anxiety and antipsychotic drugs and so on. There are also different psychological therapies that rely on different psychological principles, and some are better suited than others to some mental disorders, so we'll take a look at them. And of course, in order to understand the psychological therapies, we also need to understand some of the basis of some psychological theories. So that's why in the past we first covered psychoanalysis and behaviorist theory, because as a derivation from those two psychological theories, some psychological therapies are come up. So keep in mind that all of these topics appear on the USMLE Step 1 exam. So at the end of this lecture, we'll do some review questions covering some of the ground that we discuss here in this lecture, and kind of practicing or rehearsing for the types of questions that you will encounter in the exam. So psychological therapies, unlike pharmacological treatments, they don't really, they're not medications, but they are what's called talking cures. And I mean, you don't need to be a professional, either a physician or a psychologist, to understand that when you have a problem and you talk about it, you eventually feel a little bit better. So talking can effectively be a cure. Now, depending on the severity of your problem, talking cures need to be more elaborated. So, I mean, it's not just going to a bar and having a drink and talking to the barman about your problems at home. It's a little bit more complex than that. Psychological theories, psychological therapies have developed a series of techniques that are applicable depending on the severity and the nature of not necessarily the mental disorders, although that may be part of it, but about the nature of the problems that the patient or the client may be going through. So let's keep that. That's something important to keep in mind. Unlike pharmacological treatments, psychological treatments are not necessarily for pathological behavior. I mean, you may be going through some problems, but not necessarily having been diagnosed with a pathological condition, with a mental disorder. So psychological therapies are used, unlike pharmacological treatments, which are only used by physicians that have the approval and that have the license in order to prescribe drugs. Psychological therapies can be used by people that are not necessarily physicians, but that are mental health practitioners. In as much as they don't necessarily require drugs or medication, well, the window of people that can do it, that can perform psychological therapies, is greater. So let's keep that in mind. So there are various types of talking cures or psychological therapies, and we can basically divide them in four groups: psychoanalytic therapies, cognitive behavioral therapies, family therapies, and also group therapies. So we'll take a look at each one of them. So let's begin with psychoanalytic therapies. If you remember from our lecture on psychoanalytic theory, psychoanalysis places a lot of attention on the unconscious and also on defense mechanisms. So remember that defense mechanisms are responses. They seem to be conscious responses, although they have an underlying unconscious reality. they seem to be responses to stressful situations, and they can be either mature or immature. They can be neurotic, or they can be they can also be very constructive if they are sufficiently mature. So psychoanalytic therapies try to deal with this problem. So the object or the goal of psychoanalytic therapy is to uncover the experiences repressed in the unconscious. According to psychoanalysis, many of the problems, many behavioral problems, and some mental disorders are a result of repressed experiences in the unconscious that you may not be aware that you have them, but the psychoanalyst therapist tries to guide you through your unconscious, that is to say, to open that box and to uncover what's going on inside, so you realize what's inside, and when you come to terms with it, well, you make the unconscious conscious. You may remember from our lecture on psychoanalytic theory that this used to be one of the slogans that psychoanalysts used all the time, to make the unconscious conscious. And here the idea is that in as much as you realize what's going on deep inside you, and remember, if it's unconscious, you don't really know what's there. And there's a difference with the preconscious. In the preconscious, you may not know that it's there, but if you scratch, the memories come back to you immediately. Whereas in the unconscious, it requires more effort because if it's there, you may not have access or immediate access to those repressed thoughts. So the psychoanalyst helps you go through it and trying to find what's hidden or what lies underneath the conscious. So you see an image here of a patient laying on the couch, and the idea here is that she feels relaxed, and she tells the psychotherapist, not necessarily what's going on in their conscious because she doesn't know, but the psychotherapist encourages the patient to talk about other stuff, and as she talks, the psychotherapist begins to understand and to gather the pattern of words that come out that may be a reflection of her unconscious. So there are some techniques that psychoanalytic therapists use in order to uncover the unconscious. The first one is free association. We also cover this in our lecture on psychoanalysis. In free association, the patient just lays on the couch and begins to speak whatever is on her mind. Now, this doesn't necessarily have to be a rational speech, or it doesn't even have to make sense. I mean, and actually, the therapist encourages the patient to say stuff that does not make sense, because if you try to make sense of it, you're appealing to the ego, to the rational aspect of your personality, and that's the conscious part. But what the therapist is trying to look for is the unconscious part. So if the patient just begins to say whatever is on their mind, well, unconscious content, especially the content that's related to the id, that's not filtrated by the rational filter or even the superego, the moral filter. If people just begin saying what's on their mind, the therapist can figure out a pattern that comes out, and that may reveal part of the unconscious. And also, the therapist may be interested in analyzing transference reactions. Now, remember when we talked about the doctor-patient relationship and psychoanalysis, the transference reactions are reactions that we have towards other people that to a certain extent may resemble, not necessarily physically, it could also be psychologically or just coincidentally, there is a resemblance between other people and people for whom we have some unconscious feelings. So, for instance, if the doctor resembles a patient, if the doctor reminds the patient of someone in the patient's childhood, and that childhood was somewhat traumatic, then there may be a negative transference towards the doctor. So during this psychoanalytic therapy, the purpose here is for the therapist to try to help the patient discover what some of those transference reactions may be, and that the patient becomes aware of them so that he begins to uncover better the contents of his or her unconscious. There is also dream interpretation, which is another technique that's used in psychoanalysis. Dreams sometimes seem very bizarre. It's hard to make sense of them, but according to psychoanalyst therapy, dreams may reveal part of the unconscious. So in dreams, there are two types of content. There is a manifest content, and that is the information from the dreamer as the dreamer remembers it. So let's say that the dreamer had some dream about, let's say, I don't know, playing football or playing soccer, and there were the kids playing soccer, and the moms were cheering on, and so on. Now, apart from the manifest content, there is also latent content, and that's, according to psychoanalysis, the repressed symbolic meaning embedded within the dream. So it's usually repressed wishes, and they are the expression of the id. So if the dreamer was dreaming about playing football, well, that may be the manifest content, but perhaps the psychotherapist could argue that that has a deeper meaning that maybe the dreamer is not aware of. So maybe dreaming about football, well, maybe the dreamer is a little bit concerned of having some impacts or having some psychological clashes with other people, and that comes to be reflected as a physical clash of players during a football match, for instance. I mean, I'm just using a very raw example here. But the idea that I want to express is that the dream may mean something to the dreamer in as much as it has manifest content, but the psychoanalyst may work through and try to uncover the latent content. And that is to say, the way that those dream elements symbolize something else and that they represent what's going on in the unconscious. Now, this has been criticized on many fronts. First of all, because we're not so sure that dreams have any meaning. And the neuroscience of dreams is making way. It's making some advances, and the consensus seems to be that dreams are just meaningless. They may be residues from the previous day experiences, but they don't really, uncover anything from the unconscious. But there's also the problem of falsibility, and that is to say that it seems like the psychoanalyst can make just any interpretation, and there's no way to tell him whether or not he's wrong. So, for instance, if someone is dreaming about something explicitly sexual, then that reflects a sexual dream. But if someone dreams about something that doesn't have anything to do with sexuality, well, the psychotherapist may say, well, you may have dreamt about football, but actually football is an expression of your inner sexuality, because I know the ball resembles the testicles, and the playing football may be akin to maybe a sexual symbolism of people having sex and so on. So I mean, if you dream about explicitly about sex, then you have a sexual problem. But if you do not dream explicitly about sex, then the therapist may also interpret that you have a sexual problem. So regardless of what the dream may be, the dream will always be sexual, and this is one of the criticisms that was always labeled against Freud and against psychoanalytic therapies. It's the problem of falsibility. I mean, there's no way to tell the psychotherapist that he's wrong in his interpretation, because whether or not you dream with an explicit content, the psychotherapist will always interpret it according to his previous preconceived ideas. Okay, so having said that regarding the criticisms that have been labeled against psychoanalytic therapy, well, let's consider if psychoanalytic therapy is any good. Let's consider who are the good candidates for psychoanalytic therapy. Well, first of all, the person should be younger than 40 years of age. This person should not be psychotic. For psychotics, actually, it's very difficult to use any type of psychological therapy. I mean, the first line treatment for psychotics is pharmacological treatments, and there are some antipsychotics that we'll get to them. A candidate for psychoanalytic therapy should have good relationships with others, so there shouldn't be evidence of antisocial or borderline personality disorder, because that can be very disruptive of the therapist-patient relationship. I mean, in order to get the psychoanalytic therapy going on, there needs to be a lot of compenetration between the patient and the therapist, and because this requires many sessions, because you're going deep in the unconscious of the patient. And if the patient is antisocial or manipulative or has borderline personality disorder, which is very explosive, that could create problems. So, a good candidate for psychoanalytic therapy must be someone that has good relationships with others, and that it will not be a good candidate for conflictive for a conflictive relationship with the therapist. They should also have some stable life situations. So, for instance, not being in the midst of a divorce, because again, in order to uncover the unconscious, the patient needs to be more relaxed, and it may take some time. And also, some people have criticized psychoanalysis therapy for this. It's also good that the patient has time and money to spend on treatment, because this is a very long-term treatment. And psychoanalytic sessions can be quite expensive. And that's why, apart from the criticisms of falsibility that I just mentioned a few minutes ago, psychoanalytic therapy has also been criticized on this front, that it's perhaps too mercantilistic, because psychoanalytic therapists have been known for charging outrageous amounts of money. Let's talk about another type of psychological therapy that it's more frequently used by psychiatrists and physicians, and this is cognitive behavioral therapy. Now, there is a consensus that this is the therapy that is supported the most by evidence, and it is the most effective therapy. Now, unlike psychoanalysis, that really tries to uncover the unconscious and that requires many sessions, so you can expect to be in psychoanalytic treatment for a very long time. In cognitive behavioral therapy, the goals are much more concrete. So they are short term. They're concerned with the present situation. I mean, something that is happening to you right now and that you are trying to correct. Cognitive behavioral therapy is not concerned with the past or with deep unconscious content. So in cognitive behavioral therapy, maladaptive moods and behavior can be changed by replacing distorted or inappropriate ways of thinking with thought patterns that are healthier and more realistic. So here it's not about trying to get the unconscious, but it's actually about questioning the patient's assumptions and making the patient understand whether or not his reactions, his anxiety, his depressed thoughts, his feelings, or maybe even his delusions, although delusions are psychotic, so this is a little bit more difficult to get into, but whether or not all those thought patterns really correspond to reality. So it's pretty much a confrontation of the patient in order to ask him and make him see, question him in order to make him understand that the way he's perceiving the world is not really the appropriate way. So cognitive behavioral therapy includes self-evaluation, positive self-talk, control of negative thoughts and feelings, and accurate assessment of both external situation and of the patient's own emotional state. So if a patient comes in with very depressed, well, pharmacological treatments can be good. So there are antidepressants, basically SSRIs. But there can also be psychological therapy for depression. And in the case of psychological therapy, if it's cognitive behavioral therapy, well, what the therapist would try to do with the patient in a short number of sessions, this usually takes about maybe 10 or 15 sessions at the most, is talking to the patient in order to make the patient understand that maybe his depression is out of proportion with the stress that he's going through. So the patient is encouraged to be self-evaluated. So there are some exercises where the patient evaluates his own situation, his own life, and he begins to understand that maybe things are not as bad as he thinks they are, and he begins to develop some techniques to control negative thoughts and feelings. Now, in order for this to work, this requires good communication and cognitive skills, because I mean the therapist will confront, and not necessarily confront, but will begin a process of interaction, of questions and answers with the patient. So the patient cannot be psychotic, cannot have a psychotic disorder, because with people with psychotic disorders, it's difficult to establish a good communication and that interaction. And the same goes for people with learning disorders or language disorders or autism, I mean, or mental retardation, intellectual disability. I mean, to a certain extent, cognitive behavioral therapy is a rational process where you're trying to rationalize or not rationalize, where you're trying to put it in some reason to the patient so that the patient comes to reasonably understand that his thoughts and behavior are not proportionate to the stress that he may be going through. And of course, people with psychotic disorders or language disorders or learning disorders are not properly able to do this. So cognitive behavioral therapy seeks to modify automatic thinking. Many people that are going through stressful situations, they have automatic thinking in the sense that, you know, whenever they encounter some situation, they automatically think about some stuff that eventually leads them to, you know, some disorder in their behavior. So really the idea here is to first of all modify thinking in order to later on modify behavior. And there are many examples of automatic thinking that may be destructive, especially when it comes to mood disorders. So for instance, one example of automatic thinking is always thinking that the worst is going to happen. So you may be going through some stress, but that stress is even worsened if you immediately or automatically think that the worst is going to happen. And no, I mean, the cognitive behavioral therapist is one of his tasks is trying to make you understand that although there may be difficult situations, they're not necessarily the end of the world. Another example of automatic thinking, always putting the blame on oneself even when there is no involvement in something bad that happened. Again, this is quite common in mood disorders, in depression. So usually depressed people have a sense of selflessness, of not being worthy, of self-worthlessness. Because they put the blame on themselves and they say, oh, I'm so guilty of this, you know, it's all my fault. And again, cognitive behavioral therapy tries to modify that by making the patient understand that not everything can be their fault, that there are things that the patient just cannot control. So this is another example of automatic thinking that CBT, or cognitive behavioral therapy, tries to correct. Another one, for instance, is exaggerating the negative aspects of something rather than the positive aspects. So if you're extremely depressed because your child is going to college and you're going to stay at home, so your thoughts may be about, oh my goodness, I'm going to be alone, so who's going to take care of me? Now this is too stressful for me to cope. But CBT may, through a dialogue, may try to help you see that, well, but if your kid goes to college, that's actually a good thing because he will have more job opportunities. You will allow your kid to develop him intellectually. So although you may be stressed by this, there are some positive aspects in this experience. Now, apart from these examples of automatic thinking, cognitive behavioral therapy also tries to address some cognitive distortions that are quite common in patients. So one of them, for instance, is filtering. And filtering is concentrating excessively on the negative aspects of the situation and not thinking enough about the positive aspects of situation. So filtering is processing information but only selectively so. And this may be destructive because this may distort the way you're perceiving reality. Polarized thinking, that's another cognitive distortion addressed by CBT. Polarized thinking is, well, when you think that when you're drastic about things, when you think that things are either good, extremely good, or extremely bad, and you don't come to realize that things may be a little bit complicated, and that, you know, when you deal with people, well, no one is extremely good or extremely bad, but they're probably somewhere in between. Polarized thinking is very common in people with borderline personality disorder, especially when it comes to relating to other people. I mean, someone with borderline personality disorder may feel that someone is great, and then the next day he may think that that same person is a total asshole. So cognitive behavioral therapy tries to address this by making the patient understand that things are not either black or white, that there are many scales of gray, and that that's the way reality really works. Another distortion, overgeneralization. I think the name speaks for itself. Some people may think that if they were robbed by, let's say, someone from Venezuela, they may think that all Venezuelans are robbers and criminals, so they are very suspicious of Venezuelans, and that causes them distress because their neighborhood is full of Venezuelans. So that's overgeneralization. So the therapist in this case would try to make the patient understand that his overgeneralization is not rational, and that that's actually distorting reality, and that's causing some distress in his state of mind and also in his behavior. Catastrophizing, well, this is about thinking the worst. My kid is going to college, and I feel very sad about this, and this is going to be a catastrophe because who will take care of me? And in colleges, sometimes people take drugs, so my kid will become a drug addict, and then I won't have money to pay for his drug treatment. And being in college, there are some rapes, so my kid may be raped by some fraternities. I mean, all that stuff. It's true that sometimes it happens, but you're catastrophizing in the sense that you're taking this out of proportion. So the task of the therapist here is to make him understand the patient that he has some cognitive distortion and that this is causing distress. Personalization, another cognitive distortion. Well, this is about thinking that when you have some problems with other people, that problem is necessarily directed against you. So let's say that you're stressed because you try to go to work, and every time you go to work you're late because the subway doesn't arrive on time because there are problems in the city, and that causes you a lot of distress. Well, someone with this distortion may think that they are the object of a complot from the subway system in order to make that person specially be late to work. Personalization to a certain extent is related to paranoid ideation, and if it's severe enough it can also be paranoid delusions, which may be a sign of a psychotic disorder. If the patient is not psychotic, the psychotherapist could try to address this cognitive distortion by a series of interviews. And the idea here is to make the patient understand that some things happen and that they're not necessarily personalized against someone. Also, blaming. This may come from a defense mechanism, as we remember, of displacement when we talked in psychoanalytic theory. Blaming is, well, when you have a distortion, it's when you have a stressful situation. There's always the temptation to be blaming someone else. So, sometimes, as the slogan says, shit happens, but for us it's difficult to understand that. So we always have to blame someone. But that's not necessarily the way it always is. Sometimes just accidents happen and it's no one's fault. But we have a tendency to distort that cognitively. To think that it's always someone's fault, or even your own fault if you're the patient, which is self-blame. So this distortion is addressed by cognitive behavioral therapists. And always being right. This is more related to narcissist personalities, and if it's severe enough, it could be a narcissist personality disorder. And of course, this is another distortion. Where you're not always right. Sometimes you have made some mistakes. So the patient may be confronted by the therapist in order to make him see that he's not always right, and that maybe some of the problems that he's going through may actually be his fault, and that he needs to make some adjustments. Okay, there are other techniques for the cognitive aspect of cognitive behavioral therapy. There's, for instance, Socratic questioning. Now, we call Socratic questioning because Socrates, which is the philosopher that you have there on the slide, was a philosopher from ancient Greece who really bothered other people asking questions. And actually, he was killed for that. The Athenians were fed up with him because he was asking questions that were very uncomfortable. But the purpose of asking those questions is to challenge assumptions. So Socrates went around Athens challenging people's assumptions by asking them questions. So he would ask something like, what do you think justice is? And then someone would say, well, I think justice is so and so. And then Socrates would ask additional questions that would challenge the traditional understanding of justice. Something similar goes on in cognitive behavioral therapies. I mean, the patient may tell the therapist why he's feeling bad, and the therapist may begin to ask questions whose purpose is to challenge the assumptions of the patient and to eventually make him understand that maybe some of the cognitive processes that he's going through or some of the assumptions that he has are not correct, or they don't correspond to reality. So Socratic questioning is a very important technique when it comes to CBT. There must also be some homework in order for CBT to work. I mean, patients need to take this home and they need to exercise some of the stuff that goes on in therapy. So they need to monitor automatic thoughts. I mean, the patient may eventually help, the therapist may eventually help the patient realize that he has some distortions and that he has some automatic thinking that needs to be corrected, but this requires practice. So the patient needs to take this to his home and do some homework on it. And he must also review some previous sessions. He needs to be checking himself all the time, so this is self-monitoring, because of course if the idea here is to correct some of the cognitive distortions that are going on, well, you need to screen and check whether or not your thoughts are really accurate to reality or whether they're being distorted. Apart from cognitive therapies that seek to correct some cognitive distortions, there are also behavioral therapies, and they're closely related to them. But instead of trying to correct specific thoughts, they try to correct specific behaviors. And these are mostly used in anxiety behaviors and phobias. So, I mean, depressed mood disorders are more about the thought processes and feelings, whereas in anxiety disorders they may also be about thought processes, but also they have to do with specific behaviors. So the other aspect of cognitive behavioral therapy, well, of course, is the behavioral part. And in order to modify behaviors, there are some very specific techniques. So one of them is, for instance, systematic desensitization. And this is about increasing doses of the fear-provoking stimulus. They are paired with a relaxing stimulus to induce a relaxation response. So let's say that someone is very afraid of flying, and because of any previous experience, and they have a great anxiety about the idea of flying. Well, in order to overcome that fear, and let's say that fear of flying impairs them in their labor and their work life, because they have to travel, but every time they travel they get extremely anxious, extremely nervous, and to the point that it becomes something very stressful to them. It causes a lot of distress. Well, the way the therapist would work with this using systematic desensitization is by increasing doses of the fear-provoking stimulus while at the same time trying to get them relaxed. So you could simulate that you're going on a flight, but by doing that you're very, very relaxed. Now the idea here is to trying to make an association through conditioning, and we talked about this in behaviors theory. Through a process of conditioning, the idea here is to make an association between the stimulus that causes you distress, but also with relaxing, so that when you encounter that stimulus again, you're more relaxed. So the person eventually shows less anxiety when exposed to the fear-provoking stimulus in the future. This is very good, as I said, for the treatment of phobias. Not only for treatments of flying phobias, it could also be, for instance, for animal phobias. If you're very afraid of spiders and every time you see a spider you freak out, well, the way this could be worked out is if you go to a spa, or not to a spa, but if you relax and you listen to very relaxing music, and you sit down and you're offered some drinks, and you come to settle down. Not necessarily, not alcoholic drinks, by the way, just drinks in order to make you feel better, to make you feel more relaxed. And as you are relaxed, some spiders are shown. Now, by watching the spiders, you may eventually jump out of your seat, but then again, you are invited by the therapist to relax, to feel calm, and then working it through. Eventually, you will come to associate the originally stressful stimulus with a more relaxing stimulus. That's a systematic desensitization. Another technique is called aversive conditioning. And well, the idea here is to try to modify a destructive behavior by associating that behavior with some nasty stimulus. So this relies on classical conditioning, which we talked about in the behaviors theory lecture. Aversive conditioning, it's used to pair maladaptive but pleasurable stimulus with an aversive or painful stimulus so that the two become associated. So the person ultimately stops engaging in the maladaptive behavior because it automatically provokes an unpleasant response. Sometimes this is used with the treatment of alcohol abuse. So there are some medications that are given to alcoholic patients or patients that are struggling with alcohol use disorder, so that when they drink, they immediately feel bad and they have nausea and vomiting and so on. The idea here is to try to eradicate drinking behavior by making it aversive. That is to say, by associating extremely nasty experiences with the behavior, so that the patient eventually becomes to develop an aversive reaction to the behavior that the therapist is trying to eradicate. It could also be that the patient doesn't necessarily get the nasty stimulus, but that the patient, when doing a bad thing, but that the patient imagines the undesirable behavior instead of actually engaging in the behavior, and then either imagines or is exposed to an unpleasant stimulus. So in covert sensitization, the therapist may ask the patient to go to a party, to imagine going to a party and having a lot of drinks. But then at the same time, the therapist may ask the patient to imagine immediately after that imagination of going to the party, he asks the patient to imagine himself throwing up and feeling extremely bad. This is aversive conditioning. It's not so much using one behavior, one stimulus to change another behavior, but rather using some images to change another ideation about behavior. So this is usually used for behaviors that the therapy wants the patient to change. So for instance, smoking or alcoholism or pedophilia and so on. Now, aversive conditioning, although it has some critics, it can be used quite effectively. For instance, it's used with children who pee on their bed for enuresis. This is not being able to control urination. So when a kid is laying on bed and he pees in the middle of the night, there are some devices that are designed so that when the bed becomes wet, there is a waterproof sheet that activates an alarm. So the alarm unit sits on nightstand, and the cord connects the alarm unit to the mat. So the mat sits under fitted or draw sheet that's waterproof. So when there is a sensor that it senses that the bed becomes wet, the alarm will go off. So this will wake up the kid immediately. Now that's a very unpleasant stimulus, but it's an aversive method for the kid to stop urinating or wetting the bed. And it has proven to be very, very efficient. So aversive methods can be quite useful in some specific areas of behavior. Now, on the other hand, aversive methods have been criticized sometimes because they may seem too invasive, and also because, especially if they're not done with consent, and sometimes also because they may not be as useful as some people may think. I mean, aversive methods may work in some specific areas, but not in others. So in order for aversion techniques to work, and in order for them to be ethically accepted, it needs the consent from the patient. Remember, this goes back to the lecture on medical ethics. One of the principles is autonomy. So the patients need to consent for every medical procedure that is done upon them. And this is a picture from a very famous movie, The Clockwork Orange, which portrays aversive therapy. The main character is a criminal who is subject to a treatment that consists of forcing him to watch some images from crime, some violent images, but he has been previously given some drugs that make him very sick while he watches those images. So basically here the idea is to associate the aversive stimulus of the nausea produced by the drugs with the images that he's watching that are very violent. So the idea is that after he goes through a process of aversive conditioning, he will not feel attracted or stimulated by violence, and he will not think of committing a crime again. Now, the movie, to a certain extent, or to a large extent, is a critique of that, because, first of all, the patient, although he may have given some informed consent, he signs the papers, but he doesn't really know the full details of the experiment. So this brings into question the ethics of aversion therapy. There must be informed consent. In the past, prisoners signed papers allowing aversion therapy methods without being thoroughly informed. And in The Clockwork Orange, Alex, who's the main character, he signs the papers. He apparently gives approval, but he doesn't know the full details of the experiment. And in the movie, the aversion therapy ultimately fails. So despite the fact that he watches all those images, he still later on becomes a criminal again. And as I was saying, I mean, aversion therapy can be efficient, but only for some specific areas. So there have been some people, for instance, that have wanted to use aversion therapy in order to change the sexual orientation of people. You may have seen on the news how there are, especially evangelicals in the United States, they have conversion camps, and teenagers who are suspected of being gay by their parents are sent to those camps. And over there, the alleged therapists, because they're not really therapists, but the people who work in those camps, try to make those teenagers go back to heterosexuality and try to make them not being gay again. And one of the ways of doing this is by aversion therapy. So they try to simulate very aversive stimulus with homosexual feelings, and they try to use some of these techniques in order to change a teenager's sexual orientation. But of course, they are hugely inefficient. I mean, no matter how much aversion you put into homosexual feelings or homosexual thoughts, that's not going to change your sexual orientation. Okay, other techniques from cognitive behavioral therapy in behavior modification is floating and implosion. This works well for phobias. Now, in this technique, the person is exposed to an actual or imagined overwhelming dose of the fear stimulus. So, if you're scared of snakes, well, the patient may bring a lot of snakes, not necessarily real snakes, but fake snakes, in order to flood you with all those stimulus. So the idea here is that you become habituated to the accustomed to the stimulus, and that you're no longer afraid, because I mean, you have to handle so much stimulus that you eventually say, well, I mean, I already become used to it, so I will no longer fear snakes. So this is flooding, because it's like a flood. I mean, you really don't have time to develop a phobia, because you have so much of the stimulus on you that through the process of habituation, the person becomes accustomed to the stimulus and is no longer afraid. Another technique, it's token economy. This is used with psychotic patients or patients with a mental retardation. In this technique, the desirable behavior, so for instance, a psychotic patient who doesn't have good grooming. So if you want a psychotic patient to shave or to comb his hair and to have good physical appearance, in those cases, the desirable behavior is reinforced by a reward or positive reinforcement. So this goes back to the operant conditioning that we talked about when we were discussing our lecture on behaviors therapy, behaviors theory. You remember that in operant conditioning, there may be a system of positive reinforcements that are usually rewards. So in this technique, in token economy, the patient, every time he has a good behavior, he's given a token. It can be a coin or some money or something like that. So it is expected that through this technique, the person increases the desirable behavior to gain their reward, and it works on operant conditioning. And let's remember that There are various ways to give rewards according to the interval. So remember that if it is a fixed interval, so that every time the person does the behavior, he receives a prize. Well, in the short term that may work better, but in the long term it's more inefficient, because if a person does not receive the reward, he will not do the desired behavior. So for these types of technique, in the long term, it's better to use variable intervals and not fixed intervals. Another interesting technique in behavioral modification is biofeedback, and this relates especially well to the medical profession. This is used for hypertension, for migraine or headaches, and tension headaches, chronic pain, and fecal incontinence. That is to say, people who are not able to control going to the bathroom. So the person is given ongoing physiological information. So for instance, the person may be continuously reminded of their blood pressure. And the purpose of this is that people learn strategies that enable them to achieve voluntary control over the processes involved. So if you have high blood pressure, and you're going through the day and you become stressed and your high blood pressure goes up every time you're stressed, well, the technique of biofeedback may allow you to have a device on you that measures your blood pressure, and when the blood pressure increases, it may send an alarm so that you realize that your blood pressure is high, and then you may relax, and the blood pressure will come down. So it's a biofeedback in the sense that you're being continuously fed with information about your physiological processes. And with that physiological information, well, you're expected to learn strategies that enable you to achieve voluntary control over those physiological processes. Now, of course, some physiological processes you have no control over them, but in things such as hypertension or tension headaches or or fecal incontinence and so on, you do have some control over it. And by being provided information about the status of those physiological processes, then you may be more conscious of it, and you may be able to develop a strategy that enables you to control it better. So those are cognitive behavioral therapies. Let's talk about group therapy now. Group therapy works with groups of about 8 people, and they usually meet for 1 or 2 hours each week. These techniques of group therapy are good to treat anxiety, mood disorders, personality disorders, and to a certain extent also psychosis. They are an opportunity to express feelings as well as feedback and support and friendship to each other. So the therapist facilitates and observes the members' interpersonal interactions. So, in cognitive behavioral therapy, there are individual therapies, and in psychoanalytic therapies, there are even more individual. In group therapy, the idea is to get people together that may have a similar condition and support each other, and also by doing some group work so that in the interaction you become to have a better coping strategies, by learning what other people do and feeling supported, that having the idea and getting the idea in your mind that you're not alone in this, that other people have the same problem that you're going through, and that together you may eventually overcome it. So in group therapies, patients realize that they're not alone, and that in that sense they receive more support than individual therapy. And it is cost effective because you only need one therapist to treat a lot of patients, whereas in cognitive behavioral therapy or psychoanalytic therapy, you usually need one therapist for each patient. So in this case, it's more cost effective. In this type of therapy, the patients gain hope by watching the progress of other members and experience the satisfaction of being helpful to others. So people who go to group therapies, they really become integrated to each other, because in as much as they're going through the same problem and they're all in that together, well, I mean, you really get satisfaction when you do well to other people, when you help other people out. So this is a very constructive approach. Now, of course, it doesn't work for everything. There are some disadvantages. Some patients may be less comfortable speaking openly in a group, setting than in individual therapy. So it depends on the type of disorder that you're trying to address here. And there may some time may be also spent more time in group interaction than in the patient's actual problems. So that may be one of disadvantage of group therapy. In group therapies, there could also be psychodramas, and these are calls for the group to act out scenes relevant to the situation of a particular member under their therapist's guidance. So psychodramas are like little theater plays where the patients act out some of the problems, and with the support of the rest of the group, they work it through. Psychodramas they can be fun, and they're also efficient when it comes to addressing many problems. Not necessarily the group therapy requires the guidance of a therapist. They can also be leaderless groups. So members of the group provide each other with support and practical help for a shared problem. So, for instance, this is the way that Alcoholic Anonymous works, and also Overeater Anonymous and other support groups, where there is not necessarily a therapist, but just people sitting on a round table, and they give testimonies of their previous experiences, and they support each other. Having someone to listen to you, it's extremely powerful when it comes to psychotherapy. So even if there are no specific techniques, even if it's just telling your problems to a group of people and helping each other out, that has some really immense therapeutic effect. Similar to group therapy, in group therapy, I mean, people who previously don't know each other come together. And what they share amongst themselves is that they may have a similar problem. There is something similar, but not quite, another therapy, which is called family therapy. And family therapy is based on the idea of family systems. And this is the idea that psychopathology or other disruptions in behaviors, psychopathology in one family member reflects dysfunction of the entire family system. So if there is a psychotic in the family, maybe the problem is not only that patient, but the whole family and how the family relates to that patient. So maybe there will be therapy that's needed not just for the patient, but for the whole family, and also to learn how to deal with the challenges that patient may provide. So this parts from the assumption that the patient's behavior depends on the family, so that the family is also part of the therapy. During family therapy, there is a process known as mutual accommodation, and this is when positive processes in which a family members work toward meeting each other's needs. And it looks forward also to avoiding alliances between family members to harm other family members. So this is a variation of group therapy, but it's concentrated on family therapy and how the patient relates to the others that are also in his family. And lastly, there is supportive and interpersonal therapy, and this is aimed not at insight into problems, but rather at helping people feel protected and supported during life crisis. So this is based on the idea that psychiatric problems like anxiety or depression are based on difficulties in dealing with others. So basically here, people are coached in order how to deal with other people, and the aim is really helping other people feel protected and supported during life crisis. So the therapists try to get the patient to develop better interpersonal relationships. So it is expected that the person develops interpersonal skills in a period of 12 to 16 weeks, and there is one session per week, and it's linked to attachment theory. If you remember from developmental psychology, attachment theory is an important theory in psychology that claims that attachment is a very important human need. You remember the experiments of the monkeys and the surrogate mothers. And here the point of supportive interpersonal therapy is that the patient not necessarily he becomes attached to the therapist, but that he grows, he becomes more secure. So by receiving coaching from the therapist in order how to get along with other people, well, he has some more objects to attach to, and that allows them to have more security in interpersonal relationships. Okay, so that should be the end of our lecture. Let's do a couple of questions that resemble the ones that are in the USMLE. in order to review the contents. So let's begin with a 30-year-old man who is afraid to ride in an elevator is put into a relaxed state and then is shown a film of people entering elevators in a high-rise building. This method of treatment is best described as A. Implosion, B. Systematic desensitization, C. Cognitive therapy, D. Floating, or E. Token economy. The right answer here is B, systematic desensitization. Remember, this is especially good for the treatment of phobias. So this is when people face the negative situation that they're uncomfortable with. They usually face that by being given a relaxing stimulus, so that when they face that negative or aversive stimulus, they eventually associate it with the relaxing state. And in that way, they can cope much better with the situation that causes them stress, and eventually they become desensitized, in the sense that when they encounter that stressful situation again, they bring back more relaxed memories that are more associated with pleasant and comfort, and in that way, it doesn't give them phobia anymore. Let's take a look at another one. A 50-year-old male hypertensive patient is given ongoing blood pressure readings as he uses mental relaxation techniques to try to lower his blood pressure. This method of blood pressure reduction is based primarily on A. Reciprocal inhibition, B. Classical conditioning, C. Aversive conditioning, D. Operant conditioning, or E. Stimulus generalization. Well, this is actually an example of biofeedback. Now, biofeedback is not included in any of the options here, but biofeedback relies on operant conditioning, D. Remember that in operant conditioning, when you have a behavior, if the behavior is good, you're supposed to be rewarded. So in this case, it's operant conditioning because the good behavior of being relaxed and lowering your blood pressure is rewarded by giving you the information that your blood pressure has been lowered a little bit. So this is biofeedback. It's a biofeedback technique, and the principle of biofeedback is operant conditioning, because to a certain extent it's a reward, it's a reinforcement of your good behavior, and the reward here is the information itself.